And the topic assigned to me, Baveno 7, is also something like an ode to liver. Baveno is a place, it's a lake near Milan, where the first meeting occurred of portal hypertension, like 9 of us. And we never thought portal hypertension is an important area. It was dying. It was a rainy day, and that is the Baveno first picture, and it is classic. Every 5 years the meeting occurs, and the last one was virtual in 2021. And this time the Baveno 7 has personalized care in portal hypertension. And I'll try and run you through some of the new developments in this. This has been just published in Jan 2022. There are major 7 areas. HVPG is a gold standard. Many new things have come. But what is new is the non-invasive assessment of compensated advanced chronic liver disease. In a patient with cirrhosis, there is fibrosis and increased resistance to blood flow. To overcome that, collaterals open up everywhere, and therefore portal hypertension at the porta is determined as resistance and flow. This simple diagram, this is the barometer 0, 5, 10, 12. Normal liver pressure is less than or up to 5. Between 5 and 10 is subclinical. Above 10 is clinically significant portal hypertension. Please remember this, CSPH, clinically significant portal hypertension, when varices form, ascites develops, and complications can occur. So to make complications less, like in blood pressure, you have to reduce pressure. And ILBS, fortunately, we do the largest in the world, 1200 plus HVPGs. You have to put a catheter through the femoral into the hepatic vein. A balloon is there, and then you have a wedge after ballooning, wedging the balloon. So this was normal, it is 32. Then you release, it comes down to free pressure. So the difference between wedge and the free is the gradient. This is a work by Dr. Ankur. He had analyzed a very large number of patients and divided into 3 groups. Those who have pressure between 6 to 12, 12 to 20, and 20 or above. Those who had pressure between 6 and less than 12, that is this, over a period of 2 years, their decompensation was 11%. But if the pressure is 20 or more, decompensation occurred in 45%. Now, the subgroup of subclinical portal hypertension is more important for us, between 6 and 10. This was again divided between 2, 6 and 7 and 8, and 9 and 10. Now, those who had pressure between 6 to 8, decompensation over 2 years was 9%, but between 9 and 10, about 20%. So this means pressure has a relevance. This was another paper concurrently published by Abraldus, that between 10 clinically significant portal hypertension and bleed, so 10 to 16 and above. So 1 year decompensation, if the pressure is 12, if the pressure is 18 is 10%, if the pressure is 24, 1 in 5 in 1 year will have decompensation. So this is a very important single message. The second way we find the cirrhosis severity. Once cirrhosis has developed, there are 3 stages. These are Metavir 4A, 4B, 4C. So here thin septa and large nodule. Then in 4C, thick septa and small nodule. So how do we measure the severity of cirrhosis? HVPG and by fibrosis. Now this is a crux diagram. This is very important to understand. increasing fibrosis 4A to 4B to 4C, or portal hypertension 6 to 10, 10 or above, and higher, above 12. So these two are the ways we determine cirrhosis and its outcome. And then comes the bacterial translocation, splanchnic arterial vasodilatation, cardiac output. They keep on changing. And severity. So mild portal hypertension, clinically significant, varices, bleeding, then non-bleeding complications like ascites, and then refractory ascites. So here is a continuum of events which occur with pressure, and then you can cure. Our problem today is every time you have to do a pressure, which is not easy, painful, and you can't do biopsies every day. So we need a disease-specific, non-invasive method, and which is continuous. So this is the fibroscan, just for everyone's information. This is Professor Manoj. This was 2008 when in India this was the first machine of getting a fibro done. And those days, and I wish faculty and residents all used to do fibro themselves. This is the concept. Controlled attenuation parameter. The sound wave goes in. On return, it is attenuated by fat. This gives you liver fat. But more important is fibrosis, which is 0 to 60 milliseconds as normal. If the sound returns back fast, the liver is stiffer. 8.5 is stage 2. Now, compensated advanced chronic liver disease. This came up in the last Baveno but finalized in this Baveno. It reflects continuum of severe fibrosis and cirrhosis in an ongoing chronic liver disease. You define it that liver stiffness stratifies clinically significant portal hypertension. Decompensation irrespective of liver histology. You don't need a liver biopsy, and it is done at point of care. You done a fibro is 20, you decide. So there are two terms: compensated advanced chronic liver disease and compensated cirrhosis. They are not interchangeable but are independent. This is crux of the whole Baveno non-invasive method. And as Shalini in the last slide beautifully said, a rule of 5. Now this is green light, this is becoming red and redder. 5 is normal. If you have a fibroscan value of less than 10, then and repeated, then you exclude a chronic liver disease which is advanced. And the risk of decompensation is just 1% in 3 years. Now fibro is 10 or 15. Now this has a meaning. This now will include platelets. If platelets are good, they are above 150 and you are around 10, you don't need an endoscopy. However, if you have platelets which are lower by some mechanism, or you are around 15, you will need an endoscopy. So today, Baveno 7 decided LSM of more than 20 or platelet of 150 and less. There was a confusion which has now been clarified. Anybody with a fibro of 20 and platelet of less than 150 will require it. Sorry. The next thing is the problem related to complications. Anybody who has 25 and above kilopascal think he is clinically significant, means he has varices, he is likely to have ascites, blah blah blah. The zone between 20 and 25 is still not clear. I hope I have clarified to you who needs an endoscopy and who does not. Transient elastography can have, and this was our inputs, that everyone we see doesn't have reproducible, so at least 2 times. It should be done in fasting. Or you do FIB4 or ELF, which we don't do. The significant reduction in HVPG. Now you have a patient who is put on beta blockers. After carvedilol of 1 year, we have to repeat an HVPG. can you do by liver stiffness? So now this new definition, a decrease in LSM of more than 20% or LSM has gone below 20, which is good. If it comes to less than 10, it is fantastic. So this is a new edition, but this is expert opinion, not published anything, and we should. Now this work done by Amar was done in patients with Budd-Chiari. Pre-intervention, liver stiffness was around 60 to 65. You do a DIPS or intervention in them. These patients showed within period of 1 month the LSM has come to 20. Now we go to the spleen. This was the liver. Now spleen stiffness measurement directly reflects portal pressure. This is portal hypertension area. This is fibrosis area. This is portal hypertension. And stiffness is a reflection of congestion. Fortunately, this is easy to do because we have the best probe now. So definition. If you have spleen stiffness of more than 50, pressure is 12. It is clinically significant, about 10 and nearly 12. If it is less than 21, relax. So this work was done globally first at ILBS by Praveen. This spleen stiffness was done in controls versus cirrhosis. Here you can see controls was around 20 or 15 or so, and in cirrhosis this was high. In this is liver stiffness, my apology. The EHPVO and cirrhosis controls have liver stiffness is normal, while in cirrhosis liver stiffness is high. Now coming to spleen. In spleen the stiffness was around 20, even that our first publication. And fibroscan, spleen stiffness in EHPVO is around 70 something. So this only shows it's not a reflection of fibrosis, it's a reflection of portal hypertension. Then bleeders versus non-bleeders. So splenic stiffness in bleeders was 60 and in non-bleeders was about 30. So spleen stiffness should be done. What we are doing currently at ILBS, I am covering simultaneously. Akhil is doing all acute variceal bleeds within day 6. They are randomized. They get their HVPG, and then we get liver and spleen stiffness to predict rebleeding or effect of beta blockers. Dr. Chitranshu is doing acute on chronic liver failure, liver and spleen stiffness and outcome. And he's also looking into EHPVO and NCPF, liver stiffness and spleen stiffness. And Rajan had done earlier, and hopefully he will do again, primary and secondary prophylaxis here. Compensated advanced chronic liver disease, we have to do more. I go to the next part of, very interesting part of what is decompensation. Everyone thinks here no, but it was the most difficult part in Baveno. Decompensation is overt ascites or pleural effusion. We never thought hydrothorax is as a decompensation with a sag of more than 1.1. Overt HE grade 2 or variceal bleed. Can you imagine jaundice is not part of decompensation? Lot of debate, but people didn't know what is a normal bilirubin, so they left it. So this is an area of controversy. Now further decompensation. There is a patient who has already decompensated. What is further? So this is a new definition. A prognostic stage associated with an even higher mortality than first decompensation. 3 parts. Development of second portal hypertension driven decompensation. Ascites, variceal bleed or HE. Somebody got variceal bleed, he now gets ascites and or jaundice. Recurrence of the same event and bleeders developing other problems. Then came the concept of recompensation. Guy got decompensated, he's back. So in this fulfillment of all the following criteria, and this is experts still, all the following criteria, when you have done, removed the cause of cirrhosis, HCV, HBV, alcohol, blah blah. And this is B is most important, please remember. Resolution of ascites means he's off diuretics for 12 months. He's off lactulose rifaximin for 12 months. So don't give everybody lifelong lactulose. And he has not bled in 12 months. So recompensation must include and ascites gone, HE gone, bleed gone. And he is stable as far as his liver tests are concerned. This is recompensation and we have to work on it. I'll come briefly to acute bleed, new concepts. These are teaching slides. This is post-EVL, this is Asperter, AGA teaching slides. Now new things, and I hope our endoscopy colleagues and the anesthesia colleagues are paying attention. AVB must be managed in an ICU or immediate care. So we have a GI bleed ICU. Intubate, who should you intubate? Who is an active bleeder or has altered consciousness. Extubate as soon as possible after endoscopy. When you are giving Turley, monitor continuously sodium. Continue to give lactulose and enema. IV antibiotics. Stop PPI immediately because this leads to more infections. Don't give PPI for 5 days. It used to be common. Oral nutrition ASAP. This is expert opinion. And trainees, if you are first year, second year, you have to supervise. This is legal. What is a refractory AVB? Refractory means you can't control with combination therapies. Means vasoactives plus endoscopy. Balloon or SEMS. What is preemptive tips? Within 72 hours, preferably less than 24. ILBS normal tips is about 2.8 hours or so. Whom should you do? And this is A1. This is first rate evidence. Child C less than 14, B more than 7, with active bleeding and HVPG above 20. This is active bleeder. It is futile if CTP is above or equal to 14, MELD above 30, lactate above 12. This is B1. In ACLF, in HE or in hyperbilirubinemia, it is not a contraindication. Even if bilirubin is high, you can take up this patient if lactates are low, or you can have a MELD which is less. Next thing is do a CT or MRI to exclude portal vein thrombus, HCC, and map the collaterals. Last, quickly this part and then the next. Fresh frozen plasma, no. Platelets and fibrinogen, no. Discontinue anticoagulants until hemorrhage is under control, restart. And GOV2, IgV1, BRTO, and TIPS be combined with embolization. I know each of these are big statements. I wish I had time. Now this is a panel on a splanchnic vein thrombosis, and Dr. Dominic Wala and myself developed these consensus. First thing is that HVOTO term is dead. Only use Budd-Chiari syndrome. This is here. Budd-Chiari syndrome is the consequence of an obstruction to hepatic venous outflow. Obstruction can be located from small hepatic veins. It leaves the SOS of the entrance of IVC into RA. It is primary always unless you have an extrinsic compression. What you need to do in every patient with Budd-Chiari and portal vein is to exclude myeloproliferative neoplasia, so JAK2, and if that is negative, then you can do JAK2 exon, the somatic calreticulin mutations, and NGS. This adds another 40% to mutations. And bone marrow, in consult with hematologist. How do you diagnose? This is interesting. Budd-Chiari syndrome presentation and manifestations are diverse. Suspect in any patient with ALF. ACLF or CLD. We never think generally in patients with first and second. Demonstration of an obstruction or even presence of collaterals. Biopsy is only needed to diagnose Budd-Chiari in small hepatic veins not seen in imaging. And Budd-Chiari, this is important slide, Budd-Chiari syndrome, hepatic nodules are frequent and often benign. They may develop. Do CE, MR and CT every 6 monthly and AFP in your Budd-Chiari. How do you manage? Stepwise, first is anticogs, then angioplasty and stenting if required for short stenosis, thrombectomy, thrombolysis, TIPS and DIPS if at all, or transplant. Long-term anticoagulation to all. In Budd-Chiari, everybody. Use a Budd-Chiari TIPS prognostic index prior to TIPS. Age 0.08 plus bilirubin, 0.16 plus INR and 0.63. This has to be used. Outcome of TIPS is to decrease in ascites, bilirubin, creatinine and iron. And liver transplant if no improvement or at baseline BCS TIPS is above 7. This is Dr. Amamukund's Budd-Chiari syndrome approach. So here you have a patient who has no connection with IVC, all 3 veins are blocked or they are independently blocked with collaterals. So here you have IVC is patent, but these veins are individually blocked. Here you have just no vein available, and here what you do is you put either a TIPS or you put a DIPS. The stepwise approach is from our thinking was also dependent on the stage of fibrosis. If patient has cirrhosis, or then you will have to decongest the liver by recanalization, shunt creation, long-term anticoagulant. I don't have time, but all the BS has published extensively, but this part was not included in Budd-Chiari if Budd-Chiari occurs in a cirrhotic or a non-cirrhotic liver. So we need to work more on this to make people convinced. Go on to PVT and cavernoma. Presence of a thrombus in portal vein, and cavernoma is a network of collaterals which develops as a sequel of prior PVT. Now this is picked up from the ASLD guidelines on PVT, and Northup was the first and Baveno just adopted it. So recent, and this was also what we developed in the previous Baveno. Recent PVT is less than 6 months, chronic is more than 6 months. But what is better is it is completely occlusive with no lumen, or partially occlusive, more than 50% of the lumen is there. And Dr. Srinivas Reddy is working on this. Recent PVT in the absence of cirrhosis. How do you manage? Start low molecular weight heparin or DOACs, and you can switch over to vitamin K antagonist. Anticoagulant is minimum 6 months. You can stop it, and 1 month later do D-dimer. If D-dimer is less than 500, it is likely to remain patent. If D-dimer goes up, restart and give lifelong. Now that was without portal hypertension, without cirrhosis. Now here you have portal hypertension like EHPVO. Always there is a debate, oh, we should stop the anticoagulant. A lot of this was debated. EVL can be performed without withdrawing vitamin K antagonist, but it is C2. This data and several other data have shown. Here is EHPVO patients on oral anticoagulant, EHPVO without oral anticoagulant, and cirrhotic patients. And you can see that the number of bleeds between them on oral anticoagulant, without oral, or with cirrhosis, there was no difference in the GI bleed rate. So this became the one study and subsequently 3 more studies. So you can do banding even on anticoagulants. Second part is non-selective beta blockers and EVL should be used. Now EHPVO we see very commonly. So what are the refractory complications of portal cavernoma or PVT? These patients must be seen in a specialized center, and the reason is you can do repermeation in EHPVO. How do you do recanalization? You can go transjugular or transsplenic, and the success rates have been fairly good, and all these patients of EHPVO had refractory complications. We are lucky some of the cases have been done at ILBS going transsplenic. The new term, and which was hotly debated and I somehow do not agree, is portosinusoidal vascular disorder, PSVD. This is an umbrella. One, cirrhosis. Everything else is PSVD. This is what it is. PSVD is a broad clinico-pathological entity encompassing non-cirrhotic, idiopathic, non-cirrhotic intrahepatic portal hypertension, NRH, obliterative portovenopathy, hepatoportal sclerosis, incomplete septal sclerosis. This is one part. Part 2 is absence of portal hypertension does not rule out PSVD. Third, common liver diseases, viral hep, alcohol, metabolic, do not rule out PSVD. Presence of portal vein thrombosis also does not rule out PSVD. So PSVD is like a basket, maybe waste paper basket. How do you diagnose? The signs of portal hypertension are there. HEPG is less than 10, but patient has liver stiffness also low. You have a smooth liver surface. So many of these remain controversial. So signs of portal hypertension mean it should be more than 10. Atypical features are there. Liver blood test abnormalities and unexplained liver blood tests. I will not go into details. What the criteria approved are these. So a patient of PSVD will have features of portal hypertension, varices, bleed, collaterals. Not specific, ascites, low platelets, spleen is large. So these features PSVD, or histological lesions of obliterative portovenopathy, NRH, incomplete septal fibrosis, portal tract abnormality. What it leads us to understand, you will need a liver biopsy in every patient to diagnose PSVD, and maybe endoscopy or other tests. So today PSVD was accepted as a term because it includes all non-cirrhotic diseases. Most of them have a vascular basis, but I'll come back to it that it is an entity, it's not a disease by itself. This is all, and there was so much all for a 4-day most intensive multi-layered learning process called Baveno, and I'm leaving you with this. Judgment on Baveno 7 will come in next 5 years and Baveno 8. Believe me, Baveno 7 finished and there are 10 studies have already started globally. So the portal hypertension group in Baveno is the most active, but we have to see how far we can drive or withdraw in science. Thank you all.